Welcome to the Glassboard. Today, we are studying hematology. This is the precise science of blood, the organs that form it, and the diseases that disrupt its function. The human body requires a continuous supply of highly specialized cells to survive. The biological factory process responsible for manufacturing every cellular component of your blood is called hematopoiesis. Look at this diagram outlining the factory floor. Every blood cell you produce originates in the medulla of the bone marrow, starting with a single source, the multipotential hematopoietic stem cell, or hemocytoblast, located here at the top node. From this single origin point, the factory divides into two major lineages. This structural split dictates the ultimate fate and function of all mature blood cells in the body. On the right, the common lymphoid progenitor builds the cornerstone of your adaptive immune system, yielding T cells and B cells. On the left, the common myeloid progenitor yields a highly diverse set of tools, including platelets for clotting and white blood cells for innate immunity. To understand the pathology of oxygen delivery, we must isolate this specific pathway descending from the myeloid progenitor down to the erythrocyte. Erythrocytes are your red blood cells. Their sole critical function is carrying oxygen from the lungs to the rest of the body's tissues. Before a red blood cell reaches full maturity, it exists as a reticulocyte. These slightly immature precursors are fully functional and are actively released directly into the bloodstream alongside mature erythrocytes. Because reticulocytes are newly minted cells, measuring the reticulocyte count gives us a direct, real-time estimate of the rate of erythropoiesis. It tells us exactly how fast the bone marrow factory is currently working. So, what happens when this specific assembly line fails and a patient experiences a sudden drop in functional red blood cell mass? We call that measurable decrease anemia. Anemia is strictly defined by a low red blood cell mass, usually quantified by hemoglobin concentration or hematocrit. It is not a disease itself, but a numeric indicator of a systemic failure within the hematopoiesis factory. To treat anemia, we must first classify it. Clinicians start this process using a complete blood count, looking specifically at the mean corpuscular volume, or MCV, which measures the average size of the red blood cells. This chart shows the three morphological categories. Based on the MCV, a cell is either microcytic, meaning it is smaller than 80 femtoliters, normocytic, between 80 and 100, or macrocytic, swelling above 100 femtoliters. Morphology tells us what the defective cell looks like. We must then connect that shape to the pathogenesis, the actual biological reason why the cells are missing. There are three core mechanisms. The first mechanism is active blood loss. This ranges from acute severe hemorrhaging to slow chronic bleeding, where the body loses cells faster than it can replace them. The second mechanism is decreased red blood cell production. The bone marrow factory either suffers a structural failure or it lacks the required raw materials, like iron or vitamins, to assemble the cells. The third mechanism is increased destruction, known as hemolysis. In this scenario, the body produces the cells, but defects in the cell's shape or membrane cause them to break apart prematurely in the bloodstream. By identifying whether a patient's red blood cells are microcytic, normocytic, or macrocytic, we can immediately narrow down which of these three pathogenic mechanisms is starving or destroying the cell population. Iron deficiency anemia is the most common cause of anemia worldwide. It manifests as a microcytic anemia, and it represents the absolute final stage of prolonged iron depletion in the body. Iron presents a biological paradox. It is absolutely vital, sitting directly at the center of the hemoglobin molecule to bind oxygen, yet the human digestive tract strictly limits how much iron it absorbs from our diet. The math is unforgiving. Hemoglobin synthesis requires a steady supply of up to 35 milligrams of iron every single day. However, a normal daily diet only allows for the absorption of about 1 milligram. The supply chain begins in the gut. The 1 milligram of iron that we do acquire is carefully absorbed in the duodenum and the upper jejunum of the GI tract. Once absorbed, the iron cannot travel alone. It binds to transferrin, a carrier protein produced by the liver that safely transports iron molecules through the blood plasma. Transferrin delivers this iron to the bone marrow. Here, hemoglobin-producing cells lock onto the transferrin receptors and endocytose the iron, using it to manufacture healthy red blood cells. If there is any excess iron, it is diverted and safely banked as ferritin or hemosiderin, with the primary storage vaults located in the liver, spleen, and the marrow itself. The body covers the 35 mg daily requirement almost entirely through recycling. It breaks down old dying red blood cells and reuses their iron. Because our intake is capped at 1 mg a day, chronic blood loss throws the system into a deficit. The body drains its ferritin storage vaults to compensate. Once those vaults are empty, the bone marrow is starved of raw materials, forcing it to produce defective, undersized microcytic cells. This internal iron starvation eventually manifests externally during a physical examination. The systemic symptoms are a direct result of poor oxygen delivery. Patients present with fatigue, breathlessness, tachycardia, and a distinct pallor in the mucous membranes. But iron is also required for tissue enzymes. Severe depletion causes epithelial breakdown. Notice the smooth, inflamed surface of this patient's tongue, a condition called glossitis. You may also see angular stomatitis, which is cracking at the corners of the mouth. Physical symptoms only suggest an underlying issue. To confirm iron deficiency, clinicians order a serum iron profile to look for a highly specific inverse relationship in the blood work. First, the serum ferritin drops drastically. This confirms that the body has completely emptied its liver and marrow storage vaults. At the exact same time, the liver detects the shortage and overproduces transferrin carriers, hoping to capture any available iron. As a result, the total iron binding capacity, or TIBC, spikes upward. This creates a stark ratio. Because the bloodstream is now flooded with empty transferrin carriers that have no iron to transport, the overall transferrin saturation drops well below 15%, often falling under 5%. Finding this exact combination, a depleted ferritin vault paired with a surging total iron binding capacity, is the definitive laboratory signature of iron deficiency anemia. Let's apply this physiological model to a practical clinical scenario. Case Study 1. A female patient presents complaining of excessive menstrual cycles, persistent headache, fatigue, and palpitations. Her laboratory findings reveal a severely depressed hemoglobin level of 5 grams per deciliter, well below the normal 12 to 14 range, and an RBC count of only 2.5 million cells. Her MCV is measured at 70 femtoliters, which is significantly below the normal floor of 80. An MCV of 70 indicates a microcytic anemia, meaning the bone marrow factory is churning out cells that are significantly smaller than the physiological standard. When we pair this morphology with the clinical history of excessive cycles, the pathogenesis aligns with chronic blood loss. The combination of microcytosis and chronic blood loss points toward iron deficiency anemia secondary to menorrhagia. Her daily iron losses have exceeded her body's capacity for absorption and recycling. We can confirm this by noting what is absent. If this microcytic anemia were caused by a genetic marrow defect like thalassemia, we would expect to see extreme marrow expansion. Look at this skull X-ray. It displays a hair-on-end appearance from skeletal distortion, which our patient does not have. To formally confirm our diagnosis, we run a full iron profile. Based on her history, we expect the results to show plummeting serum ferritin alongside a sharply elevated TIBC. When managing this condition, providing oral iron replacement only restocks the factory. The primary medical directive is to identify and halt the underlying bleeding. Once the bleeding is addressed and iron replacement begins, clinicians monitor for a spike in the reticulocyte count within 1 to 2 weeks, proving the bone marrow factory has successfully resumed production. Anemia is not a standalone diagnosis. It is a measurable endpoint that, when analyzed alongside iron markers, identifies the exact point of failure in the body's hematopoietic process.